Good afternoon. My name is Andy Hashikawa. I'm assistant professor in Children's Emergency Services, and this research is in collaboration with a senior graduating medical student, Sari Wing, and our statistician, Jim Cranford. I have no financial conflicts of interest to disclose. So biosurveillance is a critical tool for early detection of disease outbreaks, resource mobilization, and efficient planning. Previous studies using surveillance of over-the-counter flu products, work and school absenteeism, search engines or social media have been limited in predicting illness trends. Our study focuses on the surveillance of children, typically ages 0 to 5, attending child care centers or preschools. Child care centers often provide opportunities for year-round surveillance compared to grade schools, which often have long summer and winter breaks. Studies clearly demonstrate that younger children in child care centers are sick early in the flu season, are sick more often compared to children who stay at home. They are also significant contributors to the spread of illness because of their naive immune systems and prolonged viral shedding, and are the cohort really responsible for the spread of influenza to vulnerable senior citizens, and their absence is more likely to indicate due to illness. The state of Michigan uses an online disease reporting system called Michigan Disease Surveillance System, or MDSS, using laboratory-confirmed and suspected flu cases. Reporters to MDSS include hospitals, clinics, ERs, grade schools, and local public health departments. MDSS does not include data from child care centers. Washtenaw County Public Health also does collect biosurveillance for schools and a small proportion of child care centers using a slow, inefficient, paper-based method that provides limited data. So child care center providers fill out weekly paper reports for GI and influenza-like illness that occur either at the center or at home. Documentation is voluntary and is faxed or mailed to Washtenaw Public Health Department weekly. Data are then hand-entered by the public health folks and then analyzed. The lag time for this whole process usually is a minimum of 2, sometimes 3 weeks. This slide shows the paper-based form used by child care centers. Only 3 categories of illness are collected: influenza-like illness, gastrointestinal illness, and chickenpox. Daily absence data are voluntary and, according to public health, are not reported regularly according to the public health. To address this gap, we created an online biosurveillance network we called sickchildcare.org. It was first piloted in 2013, starting with 4 child care centers in Washtenaw County. The child care provider uses the website to report on children that are either sick at child care or are reported absent by the parents due to illness. Each entry takes a trained user no more than 20 seconds to complete. We also collect more information than the traditional paper-based system. These includes the center's daily census, child's age range, primary illness symptoms including fever, cold symptoms, influenza-like illness, GI illness, pink eye, ear infections, rashes, skin, and lice infections. Sickchildcare.org has been accepted by Washtenaw Public Health as an official method to report illness, and communication between our 2 departments occur regularly. Since 2013, we have increased our child care centers yearly so that it has now expanded from 4 centers to 10 centers to 11 centers, and this year to 23 centers, covering about 3,500 children throughout the county. This pilot has been successful with timely and regular reporting, early detection of illness compared to grade school data. Our website has been featured in Time Magazine and IEE Magazine and accepted recently for publication in Health Security. Our first study aim was to assess the burden of influenza-like illness, or ILI, and gastrointestinal illness in local child care centers that were identified by our website. Our second study aim was to describe the capability of our website to report pediatric influenza-like illness and GI outbreaks compared to the state surveillance system, or MDSS. To assess our study aims, we extracted all cases of illness reported to sickchildcare.org between December 2013 and August 2016. We defined all cases of ILI and GI illness among these cases using the same definition as local public health. Influenza-like illness was defined as either fever or pneumonia, plus sore throat, cough, or muscle aches. Traditional cold symptoms without fever were not considered ILI. Gastrointestinal illness was defined as vomiting and or diarrhea with or without fever. We all extracted all cases of ILI within our county and GI illness within our state reported to MDSS in the same time frame. These reports were aggregate and were also lab confirmed. We then calculated the proportion of ILI and GI illness cases by week for each data set. We constructed illness curves for ILI and GI illness for each of the study years, 2014, 2015, and 2016. We then compared our website to MDSS using time series analysis to compare our illness curves. Here, we show the total number of ILI and GI cases reported to sickchildcare.org and to MDSS. Over the 3-year period, over 5,737 total illness cases were reported to our website. Of these, about 37% were ILI and about 25%, 1,500, were GI illness. During the same time, about 2,200 lab-confirmed cases of influenza was from Washtenaw County, and 42,000 cases of lab-confirmed GI illness was reported in our entire state by MDSS. Here we show the endemic curve for the proportion of ILI by week, identified by MDSS, which is the dashed line, and sickchildcare.org, which is the solid line. In our first pilot year, MDSS flu data peaked in weeks 52 and week 1, whereas the sickchildcare.org flu cases peaked in week 5. But unfortunately, our pilot data did not start until the data collection until December, and this was also a low influenza year. In contrast, in year 2, state flu cases peaked in weeks 50 to 51, whereas sickchildcare.org flu cases peaked earlier in weeks 46, 47, and weeks 49 and 50. In year 3, state flu cases peaked in weeks 8 to 10, whereas childcare.org flu cases peaked in weeks 3 and 4 and 6. Here we show the curves of the proportion of GI illness, cases by week, identified by MDSS, which is the dashed line, and sickchildcare.org, which is the solid line. In year 1, both state and our website cases peaked about the same time. In GI cases in year 2, they also peaked at the same time. In contrast, in year 3, GI cases peaked in week 3, while our website peaked in week 5. However, our website identified the rapid increase in GI cases approximately 1 week before the state's GI peak. In conclusion, our web-based surveillance in child care centers is a feasible and novel method for identification of ILI and GI outbreaks and has the potential for year-round and earlier identification of both ILI and GI illness when compared to traditional statewide surveillance. Our next steps include expansion of our website into additional child care centers. Our target currently is about 30 centers. We'd also further like to evaluate parent and provider actions for specific conditions. We also want it to be more of a bidirectional system where we provide feedback directly to the child care centers about illness trends within the local community, and also analysis of other disease trends. For instance, in 2014, during the summer, we actually picked up a large spike in hand, foot, mouth in the summer of 2014 before we had the enterovirus outbreak that winter. As luck would have it, I ran into someone at the School of Epidemiology who arrived about a year ago, and her expertise is actually active surveillance and testing in child care centers. So she is part of Arnold Monto's group, in CDC influenza group, and she has her own lab, but her experience is actually testing within child care centers. So she has experience testing surfaces in child cares and using the diapers brought in by parents. So our main goal moving forward for a research grant would be really trying to figure out if we can do anything about these illnesses. Non-flu related illness causes about $17 billion in healthcare costs. And for every kid that is sick, you have parents, and there's a significant downstream effect where they lose the ability to work. And this is estimated to be at least 125 million work days spent by parents. And hopefully we'll be able to show in the future, is there a type of cleaning products that might help decrease this amount in the future. Another thing we like to look at is we did a survey with the National Poll folks here at Mott Children's, and we asked parents where they go when their children are sick and can't attend childcare. And about 25% said they either go to the ED or the urgent care. So it's a significant problem, significant issue, and I'm hopeful that collaborating with the School of Public Health, we'll be able to answer these questions in the future. Thank you.
Hey, Andy, I have a couple of questions.
Yes.
Have you shared your data with the state?
I have. So I work pretty closely with the surveillance folks at MDSS and local public health, and we're in the process of continuing this. It's still a small sample size, but they're actually pretty impressed with how we are able to show some early detection signs. So I think moving forward with increasing the number of centers, we'll have more numbers, and yeah, they're very interested in potentially incorporating child care centers into the system. It all comes down to funding because it takes a lot to change the MDSS system, but I'd be interested in seeing if we can incorporate child care centers into their model. So.
Yeah, we say that as the new MAP system goes live today, just saying. Yeah, so anyway, other questions for Andy? Oh, great, thanks so much.
Thank you.